Okay, yeah, that's more like ignatia kind of feeling though, instead of like clearance. Yeah. Huh, interesting. No, maybe not before. All right, let's get into some viruses for the last hour, shall we? Lucy's ready. All right, we're gonna get through probably this viruses part 1. We will probably not get through RNA viruses, that whole PowerPoint. We'll see how far we get, depends on how many slides I skip. But again, as you're going through viruses, remember the goal is virus, disease, DNA, and RNA. That's the goal. If you can get there, you're gonna do pretty fine in most of your NPLEX virus questions. All right, so getting to some of our viruses. This is a great place to start. This is showing pathogenic DNA viruses. This is a table. I love tables. They're easy to study from. So we have the virus on the left. You have any association of disease in the middle and the system it's affecting. And these are all DNA-based viruses. It doesn't tell you if it's double strand or single strand. So that would be a next step layer. If you wanted to add something to this table, that would be what I would add, is if it's a double strand or a single strand DNA. We'll look at some of these a little further and define them in this lecture. But these would be important viruses to know: variola, molluscum, contagiosum, herpes simplex, varicella zoster, cytomegalovirus, and Epstein-Barr. These would be important pathogenic DNA viruses. Some others that we can continue into are human herpes virus, so 6 and 7, hepatitis B, adenovirus, HPV, JC virus, Parvovirus, B19. So all besides JC virus, all of these would be important DNA viruses to know. So pathogenic DNA viruses. Let's see here. Let's get into some specifics then. These are just talking more about like lytic versus lysogenic. So I'm kind of skipping through. So our DNA viruses, we have enveloped, non-enveloped, and enveloped single-stranded. So that's kind of how I'm going to try to categorize them as we go through. We can see on this category here, we have our enveloped DNA viruses that are double-stranded. Our pox, our herpes, and our hepatinoviruses are in this category. We have DNA viruses that are non-enveloped and double-stranded, our adeno and our polymovirus or a papillomavirus. So it'd be like our HPVs. And then we have our non-enveloped single-stranded parvovirus. So we'll take a step further and look at these groupings. So our pox viruses, remember, pox viruses were DNA double-stranded, so dsDNA. These are our eruptive skin pustules, our pox kind of lesions. They leave scars. They are the largest and most complex. They're double-stranded DNA. They multiply in the cytoplasm. They like epidermal cells and subcutaneous connective tissue, hence why where they're forming their lesions. We can see kind of some components there. The first one is smallpox. This is our first disease to be eliminated by vaccination. Inhalation or skin-to-skin contact is your spread. Your rash is going to be your main kind of virulence factor or symptom you'll see. Variola major is the real virulent form that can cause toxemia, shock, death, intravascular coagulation. Variola minor is less virulent, less disease producing. That's an example of smallpox. Ouch, not fun. Smallpox does have a vaccine, which is why we haven't seen this as of late, although we do keep the vaccine just in case. Okay, other pox virus diseases. So in this category with smallpox, there are another disease, it'd be mollusciopox virus. It's much more common. It's molluscum contagiosum is the disease associated. And this is a condition that's on your test from the mollusciopox virus. I think that'd be fair, mollusciopox virus. Same pox virus family as smallpox, but different disease. It's distributed worldwide. It can be endemic. It's really an infection of children. Direct contact and fomites spread it. In the United States, we often see it spread as an STD. The lesions are small. They're smooth macules in the genital area and thighs. And patients who have AIDS or severe immunocompromised states can get an atypical form, which can almost form a tumor-like growth to the face. And I do believe I have a picture in this presentation, so just warning if you're feeling squeamish. Okay, maybe I didn't, but I might have pictures in the future. So if you're feeling squeamish, just like, I'm sorry, I looked down. Free, we don't need to know treatment. So there's lots of different groups. We've seen monkeypox, which we've renamed since that came into the world, kind of post-COVID in that time frame. Given that it's within the last couple of years, I doubt they'll test you on that. So I'd say molluscum contagiosum, smallpox, both pox viruses, both double-stranded DNA. Those are fair game for this exam. Probably not the other type of pox conditions. So of these, which one is not caused by a pox virus? Chickenpox, yeah. So that's the great question, right? Trying to get you to pull chickenpox. That's not a pox virus, as we'll see. Now we get into our herpes viruses. So all of these members of this family have latency, so they can all cause recurrent infection. There's viral DNA here, so we'll look at some of the specificities of each of the clinically appropriate ones. But the latency and the recurrent infections can become more severe with advancing age. Think chickenpox and shingles, right? Chickenpox, obviously, typically caught when young. Shingles, when you're developing, when you're older, can present as a more severe disease. Obviously, someone who has immunocompromised state is going to be at increased risk. These are also large viruses. They're enveloped. They have the icosahedral double-stranded DNA, and they're replicating within the nucleus. So this is a large family, has lots of pathogenic disease. So we're going to go through a bunch of them. So herpes simplex 1 and 2, this is HSV. This is our most common association with the name herpes. This is going to be the fever blisters, the cold sores on the lip, or genital infections. Typically, HSV is going to infect more the face or the oral mucosa. HSV2 is going to infect more the genital mucosa, but you can see both in either place. So it's not always appropriate to say HSV1 on the mouth, HSV2 in the genitals. But either way, HSV1 and 2, those blisters, they are a herpes virus, they're double-stranded DNA. HSV3, herpes virus 3, is VZV, varicella zoster virus. This is your chickenpox and shingles virus, in the same herpes family as herpes simplex 1 and 2, but completely different virus. Think about it as being like in the same staph has multiple different types of species. You could kind of think of herpes virus as having multiple different types of species here, although it's like a step further. Herpes virus is the family, and then there's a genus species associated. So we're like one step above when we're talking viruses and these categories. That's why there's so many different types within the category that have different names. So varicella zoster virus, double-stranded DNA, chickenpox, and shingles. Then we have herpes virus 4, which is Epstein-Barr, EBV. And this is going to be our lymphoid infection, our Epstein-Barr EBV virus, a double-stranded DNA virus as well. Herpes 5 is cytomegalovirus, CMV, salivary glands, as well as other organs it can affect, but really think about it as salivary gland infection. Again, double-stranded DNA. HV 6 and 7, this is roseola. This would be one of your infantile exanthems, right? Exanthems being a viral disease that you can see in children. And then herpes virus 8, this is typically associated with Kaposi's sarcoma. That would be where I would associate that disease or that virus. These are all herpes viruses. They are all double-stranded DNA. If you know these associations, you'll be fine for almost all of these viral questions. They will likely not call Epstein-Barr herpes virus 4. They will call it Epstein-Barr. They could ask you if it's a herpes virus, though. So they could want you to know that these are all in the same classification, but they will likely not label these kind of 3, VZV, EBV, and CMV, as herpes virus 3, 4, and 5. They will call them their true names. Yes, Burkitt's lymphoma. Perfect. Yeah. Mononucleosis, correct. So splenomegaly, big symptom that you could see. All of these viruses cause latency. All of them can have reoccurrence, okay? So again, these are all classifications of all of these virus types. So if we can lump them together, so much easier to learn. You just learn like 12 viruses in 2 minutes. Okay, So a little bit more about HSV. So herpes simplex virus 1, like I mentioned, typically the mouth, HSV 2, typically genital lesions, but doesn't have to be. When it comes to transmission, again, close contact, physical contact. It can be spread though, even when there's no active lesions present, but definitely spread and transmission will increase when there's an active lesion present. Latency can occur in trigeminal ganglia for HSV1 or sacral ganglia for HSV2, but it depends on where they're infected. If you have an HSV infection of the oral mucosa, it's going to hang out latent-wise in your trigeminal ganglia. So it really depends on where that infection is actually occurring to where the latency will occur. Okay. We already talked about transmission. Really, the multiplication of HSV occurs in the cells of the sensory neurons. So if we're talking about what cell is it looking to bump into to actually be absorbed through and replicate within, sensory neurons is the cell it likes to actually absorb into and replicate. It'll then move to the general ganglia location. HSV1 typically gets in through the cranial nerve, trigeminal. HSV2, the lumbosacral spine, so the spinal nerve trunk ganglia. And we can see where that is, trigeminal nerve and then the ganglia here. Reoccurrence could be triggered by multiple different things. You can see a couple different kind of concerning issues in either children or adults. So herpes labialis, these are your cold sores. Herpes keratitis, this is ocular herpes. And so this one is more concerning because it's inflammation of the eye. The latent virus, instead of going down the trigeminal branch, goes into the ophthalmic branch versus the mandibular branch of the trigeminal nerve, because we have 3, remember? And so if it gets into the ophthalmic branch, it can actually infect the eye, and that could potentially lead to severe issues, including potentially blindness as a complication. And then genital herpes, we talked about that. Sorry, herpes lesions, I know. Where it gets really concerning is obviously in the newborn. It can be fatal in the newborn, whereas adults, we could be just fine. This is why you never have a stranger kiss a baby, right? So someone has a cold sore, has herpes HSV1, kiss an infant, transmits herpes to them. Infant doesn't have an immune system, and they can develop HSV1, and they can have a widespread systemic infection. You also could have cross-contamination by mother during birth, obviously vaginal birth. And that can infect mouth, skin, eyes, or even central nervous system. So this is why we preventively screen pregnant women. And we always want to make sure if there is an outbreak, they may deliver via C-section if there's an active outbreak during birth. And that's herpes of the newborn, poor little baby. Some other components of herpes that we want to pay attention to, again, this is all HSV 1 and 2, is the herpetic whitlow. Either or can penetrate a break in the skin, cause localized infection. Typically, this is seen on one finger. It's extremely painful and itchy. We can see this in people who work in the field where they might get exposed to HSV lesions commonly. So this is a healthcare provider concern. Obviously, if you wear gloves and wash your hands, less risk. HSV1 encephalitis is rare but life-threatening. And that's your herpetic whitlow. Ouch. Okay, great. All right, typically HSV causes what and HSV2 causes what? Cold sores and genital herpes, although either or could go either or. All right, our varicella zoster, our VCV, humans are the only natural host. This is transmitted via contact or respiratory droplets. We forget about droplets. They love to ask that about spread. So yes, respiratory droplets can spread chickenpox. The primary infection with VZV is varicella, which is chickenpox. This is your vesicles, your itchy vesicles. The virus will enter into neurons and it can remain latent. It can get reactivated as herpes zoster or shingles, and that's how it can affect the dermatome of whatever neuron it remained latent in. You'll typically see it only in one dermatomal region, and you'll see it unilaterally because it's only in one dermatome, typically only activated from one neuron. So there's your chickenpox, and then this would be an example of herpes. It was in that one neuron, and then it's traveling through the ganglia to that dermatomal region where it innervated. And that's your shingles lesion. Ouch. That one hurts too. Okay. I skipped treatment because you don't need treatment for this or even diagnosis. That's why we're just jumping right along. Our next herpes virus, double-stranded DNA viral condition is cytomegalovirus. This is where you could see giant cells with both nuclear and cytoplasmic inclusion bodies. So that could be a histological question, like a pathognomonic question that it could ask. It can be transmitted via saliva, respiratory mucus, milk, urine, semen, cervical secretions, all kinds of ways it can be transmitted. We will see it latent in a variety of tissues. The majority of infections are asymptomatic. When we're concerned is in a fetus, a newborn, or an immunodeficient adult. So that's where we can see concerning disease. Typically, though, we're infected and we don't even notice. This would be the nucleus with a large inclusion, and this is in an infected lung cell versus a normal lung cell. In newborns, if they have a CMV infection, they could see both hepatomegaly and splenomegaly, jaundice, bleeding issues, microencephaly, and even eye inflammation, and it could be fatal. Oftentimes, there'll be neurologic sequelae from this infection in an infant, potentially even hearing, vision, or mental issues later on down the road. Perinatal CMV infections are majority asymptomatic. You could have like a monotype syndrome. And then if you are AIDS or immunocompromised patients, you can get CMV mononucleosis or even disseminated, so systemic CMV, cytomegalovirus. Transplant patients are at higher risk as well. Really, you're not treating anyone unless if it's an immunocompromised person. Epstein-Barr, most of us have also been exposed to Epstein-Barr virus in our life. It infects lymphoid tissue and salivary glands. The contact is direct oral or saliva that's contaminated. Typically, college-age population is more vulnerable to infectious mononucleosis, kissing disease, kissing tonsils. Majority of people by midlife are infected previously. People who have had immune deficiencies are more susceptible for Epstein-Barr and its complications. Infectious mononucleosis, we already kind of mentioned that, but lymphadenopathy, significant sore throat, significant tonsillar swelling, and splenomegaly, it stays dormant in B cells. It can become reactivated, but it could be asymptomatic during that reactivation. This is your kissing tonsil. Some complications associated with Epstein-Barr, Burkitt's lymphoma is one of them. We mentioned this is B cell malignancy. Typically, you'll see it starting in jaw, and this will swell up the cheek. We can see this commonly associated in certain populations. One of them is Central Africa in children between the years of 4 and 8 years old. This is when we can actually see a lot of our B cells starting to really develop and to grow and to be exposed to new infections and diseases. So if they had a Epstein-Barr infection during that time and the B cells were affected, we can see that cancer display itself in those young kiddos. And you could also see a co-infection with malaria. So that's also why that population is higher at risk. You can see nasopharyngeal carcinoma as well as an association with Epstein-Barr, but I wouldn't worry about it as much. I would really have Burkitt's lymphoma, B-cell malignancy. That's a Burkitt's. Okay. This is where you can see normal lymphocytes, red blood cell versus a lymphocyte that's been affected by Epstein-Barr infection. So it's abnormally shaped, wavy shaped. Okay, moving into HHV 6, 7, and 8. So human herpes virus 6 is human B lymphotrophic virus. This is, again, saliva and secretions. It causes roseola, which is our viral exanthem, or one of them, an acute febrile disease in babies, typically under the age of 1. Fever first, and then a faint maculopapular rash. It's self-limited, so it's not going to cause any chronic conditions or chronic issues. If you got exposed to this as an adult, you could have some kind of monotype symptoms. And this is what it looks like. Little rash. There has been a relationship between HHV6 and Hodgkin's lymphoma, as well as some other cancers. HHV7 is closely related to HHV6. You could maybe associate the two of these. And then Kaposi sarcoma is associated with HHV8, which is a common tumor seen in AIDS patients specifically. You also could see it with multiple myeloma patients. So if you have Kaposi sarcoma as a question, or if they're talking about it, think HHV8 or vice versa. If you hear about HHV8, think about Kaposi sarcoma or AIDS. These three things should be linked kind of in your brain. Okay. Varicella and herpes zoster are caused by the same virus. Varicella zoster virus. All right. Hepatitis. Viral agents that cause hepatitis are inflammation of the liver. It is interesting because one of them is a DNA and the other are all RNA viruses. This is great test questions. The DNA virus is Hep B. They're all hepatinoviruses. That's the major group for the DNA viruses, is hepatinoviruses. Hepatitis B virus is a DNA virus. The RNA viruses is all the other kinds. So Hep A, C, E, and D are all RNA-based viruses. So if we look at A, B, and C, given that these are the most common ones we tend to talk about and see, we can look here and see that they're nucleic components. Hep B is the one that's different. Envelope-wise, Hep A does not have an envelope, kind of active versus chronic, incubation, etc. We've kind of already looked at some of those pieces, so really just the DNA and RNA is what I find the most interesting. As a whole, hepatinoviruses are enveloped, so Hep B, enveloped DNA virus. It can have both double and single-stranded DNA. So we already know about this. The risk for Hep B, hepatocellular carcinoma. Some of these things are already kind of redundant. We've talked about that. Okay, that's diagnosis, that's prevention. All right. So what I know about your hepatoviruses or hepatitis viruses, just know that B is the only DNA one. The rest are RNA. And that's where they'll get you. If you know that, you'll be fine for those, because they'll probably ask you more regarding hepatocellular carcinoma, acute versus chronic, the things you already know. Non-enveloped DNA viruses. We have our adenoviruses, our papillomaviruses, our polyomaviruses, and our parvoviruses. So our adenoviruses, these are double-stranded DNA, non-enveloped. There's many, many kinds that are associated with disease. They love to spread via respiratory as well as ocular secretions. They can cause colds, keratinoconjunctivitis, all kinds of different things. So we'll look at some of the specific, or we won't. Okay, we won't look at some of the specifics. Just know in general, typically like your common cold, your pharyngitis, your viral upper respiratory conditions, that would be adenoviruses, double-stranded DNA. They're not super fun to test on, so I don't know if they would ask you. Papilloma or polyomaviruses, these are smaller, they're non-enveloped, double-stranded DNA. They can cause persistent infections and tumors. We think of human papillomavirus, HPV. We can see growths, warts, or verrucas with this. There's hundreds of different strains of HPV. Obviously, some strains are more associated with cancer, cervical cancer, than others. Over time, a lot of these will regress if they do grow into warts, or it will clear on its own, but sometimes it won't. You can kind of see multiple different types of warts: common seed warts, plantar warts, genital warts. The genital wart form is the most common STD in the United States. And so these would be some of the warts that you could see. There's 9 different HPV types that increase the risk for developing reproductive cancer, and 2 as a whole count for 70% of metastatic tumors in that area. So that's why we do PAPs, to screen. Normal cervical cell versus a kelocyte or cancerous cell. Okay, hepatitis B, great. Your pallomaviruses, I wouldn't worry about these ones because this is JK and BK viruses. So I would not even know those. Parvoviruses, no. Human parvoviruses, this one you would want to know. This is your hemoparvovirus, your B19. This is 5th disease, another viral exanthem, erythema infectiosum, a rash of childhood. This is where you have the slapped like rash on the cheeks. You could have a fatal anemia if a pregnant woman transmits the virus to fetus, but erythema infectiosum as its own infection. Fifth disease is typically self-resolving. It's a viral exanthem. So this is what it looks like, that your cheeks are slapped. That's what it appears to look like. Okay, those are your major DNA viruses. I'm gonna look at RNA viruses now. It asks, before you donate plasma, have you been in contact with someone who's had the smallpox vaccine? Do you know the reason for this? Yes, because they'll test your blood, and so they'll want to know if you've been in contact with someone who's had smallpox vaccine. Why, maybe? I'm not sure. Potentially to know risk, or if you had antibodies or antigen potentially to smallpox, why that could be the case, but I'm not quite sure why they ask when you donate blood. All right, our RNA viruses are more diverse. There's 12 different families based off of envelope, capsid, and RNA genome. We're going to look at, again, only the pathogenic ones. These are the different categories, and you can see here they kind of have the single-stranded genome with reverse transcriptase, single-stranded genome, double-stranded. In below these bigger categories, you can see the disease. I wouldn't really care that you learn the big category names. I don't believe they'll test you on them. Sometimes they do. Like I've seen picornavirus used. I've seen some of these names used. So if you can remember that, great. If not, at least associate the disease itself. But if you wanted to just study single versus double-stranded for non-enveloped and enveloped, and then know your reverse transcriptase, and then look at the diseases, this could be a good place to start. So if you remember this table, you would probably do just fine in the viral section. This is our other table form that I showed you before with the virus and the disease that it causes. I think this is, again, another great study tool. Create a blank list here. So cover up all these and then match or write in your actual conditions associated with the virus, and then write down if it's single or double-stranded. That would be plenty of knowledge for this section. Okay. All right, so these are all single-stranded RNA viruses that have envelopes. So influenza is in this category. There's 3 types, A, B, and C. Type A causes the most infections, which is why we typically test for type A influenza. This is associated with our H1N1 pandemic. This is associated with the Spanish flu pandemic. So type A tends to be the most pathogenic of the types. With influenza, the virus likes to multiply in the respiratory tract. It has RNA as its genome. It does enter into the nucleus, and then the viruses will bud off the cell once they're done. So we can see here, it's going to be moving into the nucleus, going to the nucleocapsid. It has negative sense RNA, so it has to be translated into positive sense RNA. So that's why it goes all the way into the nucleus to do so. Some influenza important virulence factors would be glycoproteins, so hemagglutinin H and neuroamidase N. The hemagglutinin or the H factor is the most important virulence factor. It binds to host cells, versus neuroamidase hydrolyzes mucus and helps with budding and release. Both of them are obviously helping with infecting a cell and then breaking off and spreading from cells. Influenza is really good at antigenic drift. It's really good at mutating. That's why we have to do a new vaccine every year. And it also is really good at being able to infect other types of organisms. So really, influenza, no, it's the most virulent, is type A. Okay, I think that's the major component that I would pay attention to. Yeah. Yeah. Shift can cause pandemics. Drift is less concerning. Drift is like a slow, think of like, drift is like it's slowly kind of moving down the stream. Shift is like it moved from one stream to the next. Yeah. All right. So no influenza A. That would be the one I would know. Okay. So now we get into our next category. Virus. No. Hantavirus, sure. So American bunyavirus is hantavirus. I don't know. I doubt they'll test you on these. I'm going to skip them. I'm going to skip the ones I don't think they'll test you on. If you want to look at them, you can. Go for it. But I'm going to try to skip the ones I don't think that they'll ask you about. Okay. All right. Now we have some enveloped, non-segmented, single-stranded RNA viruses. So we will look at Rhabdoviruses because that includes rabies. We'll look at Paroxysmoviruses because that includes parainfluenza, mumps, measles, and RSV. We'll look at coronaviruses. We'll look at Toga viruses because of rubella. We'll look at flaviviruses, Hep C, and Ebola. So we will look at all of these here. These are all single-stranded RNA viruses. So paroxysmoviruses. So we have our parainfluenza and our mumps virus. Morbillivirus is measles virus. So these are important terms to know because they often, if they're trying to test you on actual viral name, they will give you paramoxovirus and they will assume that you're able to get to mumps, right? They aren't necessarily always going to say mumps virus because mumps is the condition and it's caused by a paramyxovirus. Same with measles. Measles is a condition or measles virus that's caused by morbillivirus. So you will see these terms used interchangeably in NPLEX. So these would be some name associations you should have. RSV, respiratory syncytia virus, is a pneumovirus, and this is a respiratory transmission. The envelope does have glycoproteins and F spikes that help with cell-to-cell fusion, allowing the cells to fuse together, creating that syncytium like we talk about in the heart, right? Last time you've heard of syncytium is when we talk about the ability of the heart to transmit signals simultaneously when it comes to the conduction process of the heart. Same idea here, but we're not transmitting an action potential or an electrical signal. Instead, we're transmitting viral particles, okay? So multiple cells can clump together and virus can infect all of them. They can actually fuse together and it can cause a greater infection. It also can essentially create multinucleate giant cells, cells that have multiple nuclei present. So that's what can happen in RSV specifically. All of these here would be under the paramoxovirus category. Thanks. All right, parainfluenza, it's an infection by a paramyxovirus. It's widespread as infection as influenza, but it's much more benign, typically seen in children. You could see it being as a cause of croup. So that's typically where I associate our parainfluenza is with croup. Mumps is our epidemic perititis, right? Our parotid gland inflammation. It's self-limited. It's painful swelling of our parotid salivary glands. Single-stranded DNA. Humans are the only reservoir. You typically are going to see muscle pain and malaise. Typically, it's uncomplicated. You could sometimes see an epididymis and testes infection, which obviously would be a complication in an adult male. There is a vaccine. Measles is a morbillivirus-caused condition. Red measles or rubeola, different from German measles. Very, very contagious respiratory spread, not skin spread. You can see the two different forms of measles compared here. So measles is rubeola. German measles is rubella. So measles is a paramyxovirus, morbillivirus, versus German measles is Toga virus or rubevirus. You can see the primary patient, complications, and then if there's rash present. And the kicker is in measles, classic measles, you have your complex spots in your mouth. In German measles, you do not. Both viral exanthems. This is our classic measles. The complex spots are the oral lesions, and then the exanthem because it's a classic maculopapular rash. Here's your measles. The most serious complication is subacute sclerosing panencephalitis, SSPE, which is a neurological degeneration of your cerebral cortex. Obviously, very severe. Cerebral cortex, we need that for all of our motor integration, all of our brain integration, and then obviously brainstem, autonomic system. So it can be very significant or serious. It's why we have a vaccine. RSV, a pneumovirus, you could see them used interchangeably. This is obviously very severe for an infant or small child. It causes those cells, like I said, those multinucleated cells to come together and spread infection and disease. Your big issues here is you could have respiratory distress or respiratory failure. Okay. Moving into the next category, I'm just flying through because I'm going to see how far I can get before we end. We have our rabies category, our rhabdovirus family. These are enveloped. They're slowly progressive, and your reservoirs are wild mammals, although domestic mammals can have it too. We do have vaccines for domesticated mammals. Bites and scratches or inhalation of droplets is the spread. We often think of it as a bite as the spread. The virus will grow at the trauma site first, and then it will enter into nerve endings, move towards ganglia, spinal cord, and brain. And the infection is completed when the virus starts to replicate in the salivary glands. That's where you get the foaming in the mouth, right? The clinical phases, you have a prodromal, a furious, a dumb, and a coma phase. I know. Prodromal is like your classic infectious inflammatory symptoms, as well as pain, burning, tingling at the site of the wound. The furious is when you start having agitation, disorientation, seizures, twitching, or hydrophobia. This is when the patient they start refusing water. I always think of Michael Scott in The Office when he's doing a rabies fundraiser. And he's like, rabies induces fear of water. But there you go, you're welcome. And then you have your dumb phase, paralyzed, disoriented, or stuporious. This is essentially leading you to the coma phase where you'll have death. Obviously, this is preventable. We have a vaccine. We can treat it, but you want to catch it sooner rather than later, right after the bite. This is rabies distribution based off of animal or vector. We see in the Pacific Northwest, not so much, yay. But skunks, raccoons, and fox are the common vectors that we see in the Pacific Northwest. Okay. One, I guess, pathognomonic lesion that you could see is an intracellular inclusion called a Negri body or Negri body. And this is in specifically nervous tissue, and it's contributing to this kind of agitation, disorientation, twitching, et cetera, et cetera. So this is an inclusion that can happen inside of a cell. Sometimes at NPLEX, as we've seen, they'll say post-mortem examination of the patient leads to. So that would be your pathognomonic lesion for rabies. Okay. Right. Now our coronaviruses, they have just added COVID. So SARS-CoV-2 could be on your test, although it's again like 2 to 3 years old, so maybe just the beginning stages. But coronaviruses in general cause more than just SARS-CoV-2. So they're RNA viruses, they're large, they have spike proteins on their envelopes. There's 5 different types. Prior to SARS-CoV-2, the common cold is probably the most common associated corona that we knew. They can cause myocarditis on their own, some forms. And then SARS, severe acute respiratory syndrome, was the most fatal and concerning pre-COVID-19 SARS-CoV-2. Now SARS-CoV-2 is kind of like in this range here, now that we've removed some of its virulence factors over time. This was newly emerging. Obviously, this is like older now that we have SARS-CoV-2, but this is more representative of what's on your actual NPLEX exam because they're always slow. So droplet or direct contact, respiratory symptoms may or may not occur. I would really know for coronaviruses, just know that SARS-CoV-2, SARS, and common cold come there. A complication could be myocarditis, and it's an RNA virus. That's why I would have. Rubella, we talked a little bit about this already. Rubavirus, it's a Toga virus. It's single-stranded RNA, called German measles. It's a viral exanthem. Does not have complex spots. Does have a maculopapular rash. There's 2 forms, postnatal or congenital. Congenital rubella would be if a mom was infected during first try. This would induce a miscarriage or potentially multiple birth defects. So obviously, this is where we would test mom and make sure mom has immunity or has been vaccinated or is not infected. If infection occurs during first try, though, typically miscarriage will be induced due to the infection. Hep C is a flavivirus, not but flavivirus. It is blood contact, chronic hepatitis. Most people will remain infected indefinitely, although we do have some treatments, which is great. You can get cancer from chronic Hep C infection. There is no vaccine. Arboviruses, these are your arthropod vectors, your mosquitoes, your ticks, your flies, your gnats. There's multiple different types of categories that can be spread via these arboviruses, these arthropod vectors. Some of them are mild, some of them are very significant. It's going to depend on where the vector lives, and so that's going to give a location to a lot of these conditions and diseases. And so we can see, depending on the vector, we can see where these diseases tend to be more prevalent. Probably, this is just talking about viral encephalitis. Okay, so we'll look at some of the specifics. So in the United States, we can see West Nile virus encephalitis. This is our mosquito vector. That's really what I would know here. Colorado tick fever, tick vector. So really understand like what the vector is, the condition. Rocky Mountain states would be most likely associated. Eastern equine, I don't think they'll test you on that. These two, no West Nile and Colorado tick. These two I would see more commonly. Chikungunya virus in Caribbean, Nicaragua, Central America, these are more common. Mortality is rare. Typically, these are self-limiting, spread via mosquito vector. And Zika also gets spread via mosquito vector. Symptoms like dengue or chikungunya, but you can have birth defects if the mother's infected during pregnancy, kind of like some of your other viral exanthems. The hemorrhagic fevers, yellow fever and dengue are the two that would be the most associated here. So yellow fever, there's kind of two patterns of transmission, the urban, which is humans and mosquitoes, or forest, monkeys and mosquitoes, the Sylvan cycle. So there's urban or Sylvan cycle, depending on kind of who you're around, but mosquitoes are really the vector that's causing the condition. Fever, headache, muscle pain is like the classic symptoms, but you can progress to oral hemorrhage, nosebleed, vomiting, jaundice, liver or kidney damage, and there is a pretty high mortality rate. We don't often see this in the United States. In fact, so it's relatively eliminated here, but it is still endemic elsewhere. Dengue fever, again, mosquito spread, typically not in the US, although, if we have more mosquitoes this year, maybe you can experience dengue hemorrhagic shock syndrome, extreme muscle pain and joint pain. It can be fatal. Both of these fatal, both can cause bleeding, both by mosquitoes. HIV is our acquired immunodeficiency syndrome, human immunodeficiency virus. It can lead to a severe, there's some complications that you can see here. So pneumocystis jivarsi, this is our pneumonia that can be associated with HIV, and then Kaposi sarcoma is our vascular cancer associated with HIV. So these are the two specific things, like infections, I would have as associations. But you're going to see loss of immune function over time. HIV is in the genus lentivirus, and it's a retrovirus, meaning that it encodes reverse transcriptase enzyme, which allows it to have double-stranded DNA from a single-stranded RNA genome. The viral genes will permanently integrate into the host DNA, and that can lead to AIDS. So that's kind of how that process works. But they are a single-stranded RNA virus, but it's able to reverse transcriptase itself to double-stranded DNA. Okay. There's HIV 1 and 2. They affect T cell lymphocytes. Viruses 1 and 2, they can cause leukemias and lymphomas. But HIV can only infect host cells that have the required CD4 marker plus a co-receptor. This is how you could have some people who have been exposed to HIV but are not infected. So there is this genetic component or predisposition that also can occur. So we see our CCR5 co-receptor on the CD4 cell, CD4 receptor on a white blood cell, and CXCR4 co-receptor on a CD4 cell. So they need these components for the virus to bind and then to infect the CD4 cell, T cell. Okay. This is just talking about prevalence and spread. I think that's relatively obvious. So spread, it can enter through mucous membranes or skin. It's going to travel to dendritic phagocytes beneath epithelium. That's where it can multiply and be shed. It'll then be taken up and amplified by macrophages, skin, lymph organs, bone marrow, and blood. It likes to attach to CD4 and its co-receptor. It'll fuse with the cell membrane, and then that's where it can make a DNA copy of its RNA and integrate into the host chromosome. And that's where it can either produce a lytic infection, where it can lyse those cells, or a latent infection, where it can stick around. And this is the multiplication cycle. This is describing it. Okay. The pathology of HIV and AIDS is tied to the level of virus present and the level of T cells left in the blood. So we look at both things, the how much actual virus is in the body, your virology level or your virus level, and then the level of T cells available in the blood. Because obviously as those lyse and die off, that is where we get our immunodeficiency. You can see leukopenia, so lymphocytes in particular dying off. You can see giant T cells through viral spread. You can see infected macrophages releasing viruses into other tissues like the central nervous system. And then once you start destroying CD4 lymphocytes, that's when opportunistic infections and cancers can take hold, because those T cells, those T helper cells, aren't able to help anymore because there's not enough of them. And this is your stages of infection. It can be a long, long period of time. Okay. These are signs and symptoms. I'm kind of skipping through this because I think diagnosis they won't ask you about. So these are kind of the defining illnesses. Again, Kaposi sarcoma, I think, would be the most important one to remember here. Burkitt's lymphoma can also be associated here. I mean, you are at risk for a lot of infections. I'm just looking at the ones that are very specific. Pneumocystis traversing pneumonia, that one is very specific to AIDS. Those would be the ones I would know. Okay. Great. Okay, awesome. All right, let's see here. Where are we at? Okay, we'll do a couple more and then we'll be done. So these last few non-enveloped, non-segmented, single-stranded RNA viruses, the picornaviruses, very small size. Their enterovirus form is going to be polio and hepatitis A. Rhinovirus is rhinovirus. So those are the two you should know of. Again, your enteroviruses, it has your poliovirus, Coxsackie A and B. Those would be the three I would pay attention to or know. And then rhinovirus because of the common cold. So those would be the essentially 4 total I would have that are all picornaviruses, single-stranded RNA. So we talked about, so there's polio. I'm just going to pop through and get to these tables because I think that would be the most helpful thing. If you're like not sure what's happening with polio, essentially you have motor neurons that are invaded by the virus and you'll have a flaccid paralysis. So you could compare this to our botulinum toxin, which also can cause a flaccid paralysis because it's preventing acetylcholine release. This is actually going to affect motor neurons at their core, right? Viruses can lyse motor neurons. That's why you can have a chronic post-polio syndrome where you have progressive muscle deterioration, or you could have actual long-term paralysis or damage, depending on what nerve cells were infected. You can see that kind of paralytic disease then here. Okay. Treatment and prevention, great. Coxsackie A and B, we often talk about, they're similar in its infectious characteristics, but less virulent. You see them more as respiratory infections or hand, foot, and mouth disease. It's rare to see them causing paralysis or significant sequelae. Typically, you'll see it start as a common cold like Centrum. Those are like some of the examples. Another picornavirus is Hep A. So Hep A, C, and B all have different viral sources. Hep B is DNA, Hep A and C are RNA, but their families are different, even though they all cause a hepatitis. That's why this is helpful to know. But Hep A is a picornavirus. It's an acute hepatitis. It causes vague symptoms. It's typically self-resolving. And ingestion is going to be how those two spread. Your rhinovirus is your common cold. Again, an RNA virus. I don't care about Norwalk agent. I would say rhinovirus first and coronavirus second. Third. They're all three can cause common cold though. I've seen them ask that where they've listed adenovirus, rotavirus, or rhinovirus, coronavirus, and influenza, and ask about which one does not cause the common cold. So I've seen them ask that more in that way, giving a which does not. Yeah. Or what is like, which one's RNA versus DNA? So that would be more likely what they would do. What is the most correct cause of the common cold with the correct DNA association or something like that, and give you coronavirus, rhinovirus, adenovirus, and influenza, and then also give the DNA type, and only one's correct. Yeah. The only dsDNA, so double-stranded RNA virus in this grouping, I would want you to know is rotavirus. This is oral fecal transmission. It is a primary viral cause of mortality and morbidity in diarrhea in infants and children. So, because it can cause dehydration. So this one would be the only one I would really pay attention to here. Rotavirus, double-stranded DNA, significant diarrhea in kiddos, infants in particular. Again, I mentioned prions up top. You're really only going to be asked about Creutzfeldt-Jakob disease, like mad cow disease. And really their question is going to be trying to pull you away from identifying this as a misfolded protein. That's where I see these. I'm just skipping through. Perfect. All right. Transmit the virus without the CD4 co-receptor. They can transmit, the other person may not be able to bind. All right. What questions do we have about micro? What do you need to know? My big things, know the bacteria we talked about today and their disease, their gram stain, and one other thing that you can commit to memory. That'd be great. The viruses we talked about today, know their disease. So just study the tables and their genetic makeup. I would, at this point, probably stick to that for micro. If you already have done those things, that's already in your brain, and you want to look at some parasites or some funky other bacteria or some prions, fungi, go to town. But that's going to be lower yield. There'll be questions about it. There'll be less questions than bacteria and viruses. So that'll be your highest yield stuff. Okay. All right. Tomorrow we'll talk about pathology. We're going to spend at least an hour on repro pathology since you haven't had repro pathology yet. So it's going to be a big chunk of our time. We're going to spend a good chunk on the lymphomas and leukemias and the anemias. So some of the blood diseases and disorders, because they're always asked about and always confused. And then we'll wrap up with some other pathology popcorn kind of at the end of the day to round out our last day together. Okay. Bring your questions. See you tomorrow. Yes, I don't know if Jocelyn, if you're still here, but with flaccid paralysis, you're dealing with the blockage of the release of acetylcholine from the synaptic membrane or the synaptic cleft. It doesn't enter into the synaptic cleft. So if there's no acetylcholine release, there can't be any acetylcholine to bind to the nicotinic receptors at the neuromuscular junction. Therefore, no contraction can take place. So the paralysis is flaccid, meaning the muscle's not contracting. With spastic paralysis, you do have acetylcholine release. You're not having any issues with acetylcholine. Instead, you're having the inability of actin and myosin to unbind. So actin and myosin remain bound together. And so you see that tetany contraction where your muscle is contracted and cannot relax. And you see that in tetanus. Does that make sense?
It does. So in spastic, it's like the acetylcholine is stuck.
Spastic is essentially, your acetylcholine is not being broken down effectively, or essentially it's not being bound to the receptors, and it's nothing with acetylcholine. It's not allowing the actin and myosin to release. So it's not actually having to do with acetylcholine and spastic paralysis. It's having to do with actin and myosin in the actual sarcomere.
Okay, so the actin and myosin are stuck together.
Stuck together. Yes.
Okay. Thank you very much.
Thank you. Absolutely. Thanks.